Let's talk about melanocyte tumors. The nevus is a benign proliferation of melanocytes, and the dysplastic nevus is the precursor lesion to the melanoma, which is the malignant cancer of melanocytes. And there are four types of melanoma. Two of them are so easy to recognize. There's one that's always on the palms of the hands or the soles of the feet, and that's called acral melanoma. And then there's another one that is called nodular melanoma that literally sticks up out of the skin. It's palpable, it's a bump. And so it's the only one of the four melanomas that always turns palpable. So two of them are very easy to diagnose. Now, examination questions about melanoma like to focus on diagnosis. They want to know how you're going to get the diagnosis. They like to ask, what would you do? So usually remember, you want to do an excisional or a punch biopsy of the affected skin. And the reason it has to be an excisional biopsy is because we grade melanomas based off their depth. That's called the Breslau depth, okay? And then that's how we score a melanoma and take a good guess at its risk for metastasis. So you got to take a punch biopsy, and then you're going to run some cytogenetics on it, and you're going to see if it has a BRAF mutation. That would be the most common gene mutated in a melanoma. And so the treatment for that most commonly mutated gene is called vemurafenib. That's a monoclonal antibody against BRAF. So that's the big picture of melanomas. Understand melanocytes are neural crest derivatives, so they are ectodermal. And where do melanocytes normally reside? The answer is in the stratum basale, or the most basal basement layer of the epidermis. So the basal layer is filled with basal cells, which proliferate and divide and turn into keratinocytes, which detach from the basement membrane, lose their proliferative capacity, and eventually dehydrate and slough off. So the melanocytes are clear cells, like I've circled in green here, in the basal layer. That's very important. And melanocytes themselves are not actually too heavily pigmented. On a normal H&E, what they do is they synthesize pigment, that's called melanin, and then they pass that pigment off to their neighboring cells. And so actually every single cell in the epidermis has a little bit of pigment that that cell has acquired from a melanocyte. So again, the melanocyte makes this product and then exocytoses it in vacuoles, and it diffuses into normal skin cells that otherwise would not make any pigment of their own, but they are pigmented due to the activity of melanocytes. This is a melanoma. On the left, a singular melanoma. On the right, plural. Many different foci of melanoma covering a patient's arm or leg. And you can tell right off the bat that this is a asymmetric lesion. There is not a good way to draw a line and split this lesion into two symmetric halves. So asymmetry is a big diagnostic quality of all melanomas. You can also tell that it's fairly uncircumscribed. It's got some areas with very clear margins, but it's got other areas, such as in the top of this photo, where the margins start to fade and become sort of blurry. And so that's also another diagnostic criteria of melanomas, the lack of nice, clear marginations around the edge of this skin lesion. It's also very dark and pigmented, and we're saying very, very dark because, again, the melanocyte is the cell that makes melanin, which gives pigment to your skin. And so even if you're just the whitest dude on the block, like this patient on the left, a melanocyte tumor is still going to appear very, very pigmented, again, even in the palest of folks. And this is a primary melanoma. You can have melanoma metastasize to different organs in the body. It can be a pretty invasive tumor. One spot it likes to go is inside the GI tract. Here's a melanoma lining the wall of the duodenum. See, it's polypoid in nature. And it is, again, still, even though it's in the GI tract, it's still heavily pigmented. Another couple of examples here. There's 1 and 2 melanomas, again, growing on the wall of the gut. Here's metastatic melanoma that's found its way into the liver. Again, heavily pigmented nodules. And then here's a melanoma in the eye. But interestingly enough, iris melanomas tend to be primary tumors themselves rather than metastases, and that's because you do have a layer of melanocytes inside the iris of your eye that gives it pigmentation. The reason being that you want to direct light through your pupil, and so you want to reflect all light around your pupil to kind of create a funnel for light into the eye. And so the function of melanocytes in the iris of the eye are to produce pigment, which then reflects light so that you can have a more focused visual field. Here's a photo of the Breslow depth. And the Breslow depth is going to be the most important prognostic factor in predicting a metastasis of a melanoma. So what we do is we punch biopsy the tumor and we measure its depth top to bottom. That's how easy it is. And if it's less than 0.76 millimeters, that tumor is not going anywhere. 0.76 is the magic number. If it's 0.77, it can metastasize, okay? So anything greater than 0.76, it is at risk for systemic metastasis. If it's under that, you're cool. Monitor. So some important principles there. A nevus is a mole. And a nevus is a benign proliferation of melanocytes. So the melanoma, again, is the malignant, aggressive, invasive tumor. A nevus it's a neoplasm, kind of, but it's not going anywhere. It's benign. So that's what a nevus is, and there are a few types of nevus, and then there's also a dysplastic nevus, and that dysplastic nevus is what's particularly the precursor lesion for melanomas. Let's talk about acquired benign nevi. These are going to be symmetric, and these are going to have regular, well-circumscribed borders. These are two features that set them apart from melanomas, which remember are asymmetric and can have blurring of their margins. So the four types of acquired nevi are lentigo, and that just means basically biconvex in shape. I'm thinking like lentils. That's a pretty good food, actually. I could talk about lentils all day. I think they've got the most protein out of any plant, actually. So lentigo is going to be proliferating nevus cells, so benign melanocytes that are limited to the basal layer of the epidermis. I think I've got some photos here. So you can tell it's a small little spot, it ain't nothing doing there. And if you were to look on biopsy, you would see melanocytes. There's a fair amount of them there, but they're not growing into the dermis. And so that's what makes a lentigo. Lentigo is that there's no dermal proliferation. Then there's a junctional nevus, in which nevus cells start to form nests. And it's called junctional because these nests are located at the dermoepidermal junction. And a couple other types of nevus are the dermal nevus, in which the nests are a little bit deeper down into the dermis rather than at that junction. And then there's the compound nevus, in which you see nests of neval cells at the junction and deeper in the dermis. And so, oh man, I feel like I'm just like beating a dead horse here reading this stuff, but here's a junctional nevus in which you see nests at the dermoepidermal junction. Okay, so right at the border between these two territories. Then here's a dermal nevus where all of the nests that you see are deeper down in the dermis. Our dermal epidermal junction is up here, and you're not seeing any nests of nevus cells up there. And then here's a compound nevus in which, yes, here are some dermal nests that are purely in the dermis, partnered with some nests that are higher up at the dermoepidermal junction. So in recap, lentigo, it's purely epidermis, you don't see nests. Junctional nevus, you see nests at the dermoepidermal junction. Dermal nevus, you see nests in the dermis, but not at that dermoepidermal junction. Compound nevus, you see nests both deep within the dermis and at the dermoepidermal junction. So again, one more time, that is the benign proliferation of melanocytes. And those benign proliferations sometimes, very rarely, can become cancerous. And a risk factor for predicting if a patient's going to have a mole that turns into a melanoma is actually the total number of moles that that patient has. that's discussed at the top of page 5 here. And for any individual nevus, the size of the lesion also correlates with its potential for malignant transformation. So we've got two pretty big risk factors here for transformation. Number one is going to be the total number of benign moles that a patient has. And out of any one individual mole, the risk factor is going to be just straight up the size of the lesion. So then there's a couple of variants of acquired nevi. The halo nevi or halo nevus is named so because you see a halo of lymphocytic infiltrate around it on biopsy. So just associate the lymphocytes here with the halo nevus. And then there's blue nevi, and I think that this is the one that you see in, man, we've seen some disease with blue nevi, and I wanted to say Peutz-Jeghers, but I actually don't think that you get nevi and Peutz-Jeghers. I think it's something else there. Maybe it is. But they're blue. That's about all you need to know. Dysplastic nevi, you start to see degrees of atypia. And again, this is the precursor lesion to a melanoma. Dysplastic nevi are larger than 5 to 6 millimeters in diameter. And that's in comparison to typical non-dysplastic nevi that are smaller. If you were to biopsy a dysplastic nevus, you would see nests of nevus cells. And again, they're going to have some degree of atypia. They're going to be beginning that long march towards malignant transformation. And one more time, the dysplastic nevus is the precursor lesion for malignant melanoma. So now there's this FAMMM syndrome, SUPFAM, you know, like familial atypical multiple mole melanoma. So these patients have a family history of melanoma, and they got to tell you that in questions, Tim, if they want you to diagnose FAMMM. What's the gene involved? Cyclin-dependent kinase inhibitor 2A, which produces both the P16 and the P14 proteins. And those are guardians of the genome, tumor suppressor gene. You know, they are going to stop cell cycle progression forward. If you want to get really specific, you can understand that the P16 gene blocks G1 to S transition, but the P14 gene can also block G2 to M transition. And this is an autosomal dominant syndrome that usually presents in children and teenagers and is highly correlated with adenocarcinoma of the pancreas. So what could they possibly ask you about familial atypical multiple mole melanoma? Well, number one, they could say, what's the gene involved? Number two, what's the protein involved? Number three, what's the inheritance factor? Number four, what other cancer would you expect to see in this patient? Now let's talk about melanomas. A melanoma is a malignancy of melanocytes, and when a melanocyte has become malignant, we know that that tumor has become particularly invasive. It's encroached through the basement membrane. It's gone off sides, and it's now got the capacity to metastasize elsewhere in the body. Now, before we talk about the subtypes of melanoma, it's important to understand radial and vertical growth. Most melanomas grow radially. The nodular melanoma grows vertically, and vertical growth is the worst kind of growth for a melanoma because going back to this Breslow scale, or Breslow depth, right? The depth of a melanoma is going to predict how likely it is to metastasize. And so if a melanoma is growing in the left and right dimensions, you know, if it's growing on the x-axis, that's not the coolest, but it's relatively cool compared to if it's growing on the y-axis, because if the melanoma is growing up and down, that means it is getting deeper into the skin and hence more likely to metastasize. And so that radial growth is a lot cooler than vertical growth. And there's one particular type of melanoma, the nodular melanoma, that loves to go through vertical growth. In fact, that's just about all it does is grow vertically. So first, let's talk about the superficial spreading melanoma. This is the most common melanoma, and it's also the one seen in the youngest patients on average. The median age for the superficial spreading melanoma is 30 to 50, whereas the median age for other melanomas is in the 50s and 60s. So this melanoma does not have a huge association with sun exposure. Some of them do, but the superficial spreading, again, the most common, does not. What does the superficial spreading melanoma look like? Here are some typical examples. Notice the asymmetry. Notice the poor margination on the border. Notice the dark coloration of it. Also notice that we're running down the ABCDE of diagnosing malignant melanoma, which stands for asymmetry, border irregularity, color, diameter, and evolving. So it's got to be greater than 6 mil. And it's also got to be changing over time. When the patient follows up with you, you're going to notice, maybe if you're a particularly sharp guy, you're taking a photo of that melanoma to have something to compare it to. And so that ABCDE criteria is going to help you diagnose malignant melanoma. So again, one more time, we look at it, we've got asymmetry, we've got fuzzy borders, we've got a dark color, we've got a large diameter, especially in some of these cases, you know, like getting up into the centimeters here. And then if these were evolving over time, we would go ahead and say, all right, let's take a biopsy and check for melanoma. So what do you see inside a melanoma? You see nests of melanocytes, and recall that melanocytes are relatively clear inside their cytoplasm. You can sometimes see them stain. You can sometimes see the granules within their cytoplasm stain for some dense pigment, but normally their cytoplasms are, you know, pretty transparent, pretty opaque. So nest here in the epidermis, nest here, and these are all epidermal nests, and you can start to see lymphocytes in the dermis down here. If we zoom in again, notice you're looking at cells that have way less coloration to them than the surrounding keratinocytes up here, you know, and then the pink connective tissue of the dermis, and then these lymphocytes down here. So you know you're not looking at lymphocytes or keratinocytes or fibroblasts, and so melanoma is really process of elimination. It's like, yes, I have to be looking at a melanocyte proliferation here. Here's another look at superficial spreading. We can see some nests of melanomas. Here's one up here, a couple here. And these nests, again, are occupying the reedy ridges. You can start to see some nests of melanocytes as you get farther down into the dermis. Here it is again, same thing. We're looking at these nests, which are typically spherical, but the image I want you to have in mind is going to be kind of like the large intestine. Remember, histology of our bowel, our small and large intestine, kind of has some crypts to it, you know, and some glands that are going to put secretory products into the lumen of the gut. And so those glands often look tubular on histology, even though they're shaped kind of cylindrically in the body. So we've got these nests of pretty clear melanocytes. Here's one down at the bottom that's getting into the dermis. And that's your superficial spreading melanoma, which is the most common. Now, this lesion may start to bleed. It may start to ulcerate. It can itch very uncomfortably. It can even start to cause the patient a lot of pain. So those are going to be different symptoms that clue you into, oh, this is not just your run-of-the-mill benign nevus that I'm dealing with. This could be a tumor. So in words, the SDL tells us on histology to look for dermal nests and epidermal nests of melanomas. And one more time, it clues you in that there's a difference between radial x-axis and vertical y-axis growth of these melanomas, and vertical growth predicts spread. So speaking of vertical growth, here's your nodular melanoma, which you can usually diagnose this clinically without needing the biopsy. You know, I mean, you get the biopsy anyways, but this is the one melanoma that is super palpable. It sticks up like a bad case of acne, like a bad zit. It sticks up, you can palpate it. And again, might hurt, might ulcerate, might itch. This melanoma grows very quickly, and it is the most aggressive subtype. Out of all melanomas, this is the most fatal subtype. Here's a nodular melanoma. You can tell, like just by the light reflecting off of this image, that you can rub that melanoma and palpate it. You can tell that it feels like a bump. Same thing with this one over here. You can tell it's got this flat lesion on the right side of the photo, but then in the middle, I'll circle in red, is this part that it looks like you could just put your thumb on and rub and feel. Okay, so that's a nodular melanoma. It's got that vertical rather than the radial growth. And then other than that, notice it meets all the other criteria of our diagnosing melanoma. So the asymmetry, right? You can't draw one line through this. And then the border, it's got some fuzzy, blurry marginations. And then the color, it's certainly darkly pigmented. What else do we have? Diameter, that looks like it's greater than 0.6 millimeters, or 6 millimeters rather. And then what was the last one? Evolution over time. Yep. So nodular melanoma, other than the height, I mean, it's exactly the same as any other melanoma. This is a good little graphic I found. You know, we got an A, B, C, D, E for every melanoma, but for the nodular melanoma, you can add an F and a G, firm to touch and growing. Here's histology of a nodular melanoma. You can tell here's the skin, and then bang, this nodule just takes off. Not much to say. I mean, that's very apparent. The melanocyte tumor is just entirely within this area here. So you can, it's a large tumor. This is a low power. And here's another look at a similar tumor where it's clearly peeking up from the skin. It's clearly a palpable bump, and you can tell that the melanocytes infiltrate way, way, way deep down into the dermis, and that they're just everywhere inside this tumor. So that's a nodular melanoma. What else does the SDL have to say about it? Not much else. Again, it's papule or dome shaped. It's clearly elevated, and it's got a rapid growth phase with a poor prognosis. So now let's talk about Lentigo maligna melanoma, and I'm going to time out here and say this is the one that's you're probably most likely to confuse this Lentigo maligna melanoma with the superficial spreading melanoma. So the nodular melanoma, the acral melanoma, it's like, duh, you can't get those confused with anything, but let's pay attention here and try to figure out how we can tell the superficial spreading apart from the Lentigo maligna, because that's going to be the only real differential you have to worry about. So the Lentigo maligna melanoma is correlated first and foremost with this precursor lesion, solar elastosis. And all that means is that you get a lot of wrinkles because you've been out in the sun. This is an example of solar elastosis. Again, that's just sun damage because you've got elastic fibers in your skin that pull it taut. And if they lose their contractility, then your skin is going to start to sag in certain places. You'll see creases and wrinkles on your face. So that is solar elastosis, loss of the elasticity of the skin, its ability to snap back into place after being deformed. So that's what you would see concurrently or as a precursor to a patient with Lentigo maligna. Here's what Lentigo maligna looks like. Very commonly on the face. Always see this in sun exposed areas. So patient comes in and they've got a melanoma, like, you know, right next to their umbilicus. Well, unless they're suntanning every day of every week, you know, that's not a Lentigo maligna, because these things are very heavily associated with sun exposure. So typically it's the farmer, you know, or the fisherman, somebody who works outdoors very frequently, and they come in. And again, this Lentigo maligna is on an area of sun exposed skin. Chronic sun exposure, UVB light, is the #1 risk factor for this particular type of melanoma. You typically see it in about the 6th decade of life, and these can get very large. The superficial spreading likes to stay small most times, but this Lentigo maligna, I looked for photos of it online. I found a ton where the patch of the melanoma was just, you know, in the inches ballpark rather than the centimeters. So if we were to biopsy this, we would not really see nests so much as we would see just a straight up epidermal proliferation of melanocytes. Again, compare that to our superficial spreading. There's nests in every single photo of superficial spreading that I could find. There are these circular tubular nests, but then you look at Lentigo maligna, and again, it's less nests, more like a solid layer of melanocytes under the surface of this tumor. So going back to the SDL, first and foremost, these Lentigo malignas can reach quite large size. Again, we're talking inches, not centimeters there. Cumulative long-term sun exposure is believed to be the greatest risk factor for developing Lentigo maligna, and that is opposed to intermittent sun exposure, which was our risk factor for the first type. That's solar elastosis again. And what do you see on histology? Neoplastic melanocytes arrayed along the dermal epidermal junction in a lentiginous pattern against a background of epidermal atrophy. Now let's talk about acral lentiginous melanoma. Acral is referring to the palms of the hands and the soles of the feet. This is actually the most common type of melanoma amongst Japanese, African Americans, Latin Americans, Native Americans. So a whole lot of people have a tendency to get these melanomas on, again, the palms of their hand and soles of their feet, which is why you always got to check out a patient's feet, especially if they haven't seen a doctor in a long time, because most people are not sitting at home just checking out the soles of their feet. You know, it's like, I don't know about you. Maybe you're one of those people who just sits at home, stares at their feet, but not me. I could have a melanoma on my foot right now. I couldn't tell you, you know? So it's like you, the clinician, have to be the one to check for that, because this is very, very common and you don't want this metastasizing elsewhere in the body, yo. So some photos. Here it is. Pretty self-explanatory, right? It's like, that's a melanoma. That's a melanoma. That's a melanoma too. So have a healthy dose of suspicion for lesions that you observe on the hands and feet. Again, you're observing for asymmetry, border, color, diameter, and evolution over time. That's about all I need to know with that one. It's not associated with sun exposure. Like, how could it be? You know, we're not out here tanning the bottoms of our feet. I don't know though. I mean, it's like people these days like must tan the bottoms of my feet. So risk factors, when we're talking about sun, understand that sun UV damage creates thymine dimers. You've seen that before. You know what that is. And this is called a transition. That's the specific vocabulary word for this. And a transition is the replacement of one purine with another purine. So A with G, or one pyrimidine with another pyrimidine. So for example, C with T. So that's an example of a transition. You want to know this word because I could just about guarantee you we will see this word in a test question, because if I was writing a test question, it's an easy question. You just got to know what a transition is. And so if you don't read this STL, maybe it just goes over your head and you miss out on that point. So it's a C to T transition. You get thymine dimers. And what gives you this? UVB light. Okay, let's zoom in. Look at this here too. UVB radiation appears more closely associated with the development of melanoma than UVA. So I could also see this being a question. You know, it's like, okay, here's a patient with melanoma, like it's Lentigo maligna, so chronic sun exposure is the big risk factor. And then they say, what predisposed the patient to this cancer? And it's like, A, UVA light, B, UVB light, you know. And then it's like, so half the class is just sitting there like, oh, word, yo. So the answer to that question, if they were to ask it, would be UVB light. UVA light, by the way, that's a black light, like in a tanning bed, you know, or when we're using a Woods lamp, you know, that tool that we can use to do a quick assay of the conjunctiva and the eyes, right? If somebody's got a foreign body, we want to Woods lamp it. And that's also how we diagnose herpes simplex conjunctivitis, right? So that's just a black light. That's UVA light. UVB is the type that likes to cross-link the thymine dimers. So xeroderma pigmentosum, we love this one. Why? Well, because the gene, I think, is called XP. Like, I think it's just literally straight up the xeroderma pigmentosum gene, and it's nucleotide excision repair. Easy money there. Patients can't go outside. They blister. They get cytopenias. They get anemias, and they are prone to get melanoma. They will typically get skin cancers of all shapes and sizes, starting at about age 5, 6, 7 or so. We did say that acquired nevi are risk factors for melanomas, and we said that the dysplastic nevus particularly is the precursor lesion to the melanoma. And we also said that two things particularly are predictive. Number one is the total number of nevi that you have. So if you're like 0 to 20, you're pretty cool. But if you're in the 50 to 100 range, then you're at a higher risk. Now, docs, please don't waste your time doing this. Yo, like, tell the patient, like, hey, can you have a family member like count this? I'm gonna go do something else right now. Don't just sit there and count every freckle on the patient's body. And then we also said that the size of any particular nevus is the best predictor of if that specific one is going to transform into a melanoma. Last but not least, BRAF, V600E mutations, most common mutation in melanomas. The treatment that we have for that is vimurafenib. That's a monoclonal antibody against BRAF. And here at the end of this diagnosis, let's talk about this because, again, they love to ask diagnosis questions about melanoma. A lot of people could say, ooh, that's a malignant skin cancer, you know, especially if it's big and bad. But what do you do to confirm? So number one, you take an excisional biopsy with narrow margins. How narrow? 1 to 3 millimeters. Superficial shave biopsies are discouraged because partial removal of the primary melanoma may not provide an accurate measurement of tumor thickness, which is the most important prognostic factor for cutaneous melanomas. Repeat, tumor thickness is the most important prognostic factor for cutaneous melanomas, and we call that the Breslau depth of invasion. In this chart here, if it is less than 0.76 millimeters, there is a 0% chance that that patient's going to have any positive lymph nodes in the area. But as soon as you cross 0.76 millimeters, then you start to see a little bit of a chance for this sucker to invade locally. And then the higher that depth gets, the greater and greater your risk of distant metastasis. So that's melanomas. Not a whole ton going on here. Again, please remember these 4 separate subtypes. They are pretty easy to tell apart. Here's first aid. We can summarize it here. So we're going to see that S100 tumor marker because this is a cell of epidermal origin, right? It comes from the neural crest, ectodermal origin, neural crest, S100 positivity. Big risk factor is sun exposure for some subtypes more than others. Dysplastic Nevis is the precursor lesion. The Breslau thickness correlates with the risk of metastasis. 0.76 mils is your magic number. We've got an A, B, C, D, E diagnostic criteria that diameter has to be greater than 6 millimeters. If it's less, then it's pre-malignant. There are 4 different types. Superficial spreading, most common, most likely to be seen amongst young people. Nodular, that's a palpable melanoma, right? And that is also the most aggressive. Lentigo maligna, that is highly correlated with areas of sun exposure. So if you see one on the face, it is most likely to be lentigo maligna. And then acral, if you see an acral melanoma, that's most common in many different populations, and that's on the palms of the hands, the soles of the feet. This BRAF kinase is usually mutated in melanoma, and so one of the most popular treatments that we have for melanoma is vemurafenib. One more time, you have to take an excisional biopsy with appropriately wide margins. Those margins are at least 1 mil up to 3 mils. So that's a melanoma. Let's go get that money.